49% people believe that healthcare in a way is a social uh, issue, not a medical issue. I think that is really encouraging, given the scope of Project Echo. Now stop the result for this, and I would love to run the second poll. Here is the second question for you. Those who have joined, I would request you to participate in this, and welcome to Ahmedabad University. Just as a reminder again, I would request, this is just a kind of admin alert, that those who are joining from their mobile, I request you to please rename yourself once you join so that your name is visible, not the mobile's name, your cell name. 10 more seconds for you to participate in this poll and give your views. Thank you so much. Now I'll share the result for this one. And I hope our speakers today are taking note of it. If you would like to address some of the issues in your talk today. Generally, somebody is saying that I would love to have more options, but we try to keep it like this so that we get the black and white opinion. That is one trick that we play. That is really a fun, but we keep it in that way so that we really get to know what do you think in black and white. I hope you have seen the result of this one. I'll run another one quickly. And here is the question for you, 10 more seconds. Thank you so much. 5 more seconds, and then I'll share the results. And I'll request for your patience for half a minute because people have started suddenly joining in. So we'll begin in 30 more seconds. Here is the result for the last question. And it is very obvious to the panelists and to all of us. People believe that video technology and delivering medicine through alternative method is one of the ways through which we can reach out to those people who does not have proper access to the healthcare in India, and that may be true to whole entire world in such countries. Now, without delaying it, because it is a time-bound activity and we have our three speakers here, I welcome everybody to Ahmedabad University. And just to tell you that this is a conversation series. Thank you so much that you all have registered. The idea of conversation series is from management school. We have this series, which is, I think, 12th in the series. This is the talk that we are having. And the topics range from healthcare to supply chain to new world of work and other topics which are very relevant to all of us. And the idea is that we get the top industry person or top practitioner from the field and one professor from our Amrit Modi School of Management. And they both interact on a topic which is really relevant. And we are also thankful to this digital world and to Zoom that we get to see and get to invite such eminent people in our panel, and a lot of people benefit from this with this kind of technology. Uh, Without delaying, I would like to introduce the panel quickly. And I am personally really excited to introduce Dr. Sanjeev Arora. Dr. Sanjeev Arora is the director and founder of Project ECHO, very well-known name in healthcare sector. He is a distinguished and Regents Professor of Medicine with tenure in the Department of Internal Medicine at the University of New Mexico Health Sciences Center. Born in Nangal, India, Dr. Arora was raised in a household of physicians, which gave him a strong sense of responsibility to give back to his community and country from a very early age. And in 1980, he moved to New York and later Boston to study medicine and become a GI doctor. He's also Dr. Sanjeev Arora is also a Ashoka Fellow, and he's a recipient of the 19th Haynes Award for Public Policy from Teresa Haynes and Haynes Family Foundation. That is truly a magnificent honor to have. Dr. Arora received this award on behalf of Project ECHO's dedicated faculty, staff, and partners. As a part of his illustrious career in New Mexico Health Sciences Center in 2003, Dr. Arora developed the ECHO model and founded Project ECHO, which means Extension for Community Healthcare Outcomes, as a way to dramatically improve both capacity and access to specialty care for rural and undeserved population. Project ECHO uses simple video conference technology to link expert interdisciplinary specialist team with primary healthcare people through tele-echo sessions in which the experts telementor the people to treat complex conditions using case-based learning and guided practice. He has written a lot of paper. He's a well-known name, and we are truly delighted to have Dr. Sanjeev Arora at Amrit Modi School of Management, Ahmedabad University. Welcome you, sir. Second speaker in the series is Dr. Sunil Anand. He's a graduate of the Armed Forces Medical College, Pune. He has postgraduate diploma qualification in both general medicine and anesthesia, and was trained as anesthetist and intensive care specialist in the United Kingdom. On his return from UK, he founded and managed a healthcare company for over 2 decades and now serves as the executive director of ECHO India. Thank you so much, Dr. Sunil, for accepting our offer and to be on the panel. We are thankful to you. And third speaker in the panel is our very own colleague, Professor Pallavi Vyas. She holds a PhD in public policy from Harris School of Public Policy, University of Chicago. Fields of interest are poverty, inequality, human capital theory, public health, and labor economics. She is currently an associate professor of economics and public policy at Ahmedabad University. Pallavi also consults at the World Bank, where her projects are on poverty, health, and nutrition for South Asia and access to justice in 14 different countries. Pallavi has also worked as an economist in economic litigation consulting at LECG in Los Angeles. Her work included analysis in antitrust, securities, brand valuation, corporate level cases. Prior to joining LECG, she worked at the Milton Institute of Santa Monica as a research analyst. And it is always a great honor and pleasure to welcome and introduce your own colleague. And I have this unique opportunity because I have been introducing our very dear colleagues for the past 12, 13 rounds of webinars. So thank you so much, everybody, for joining. And over to you.
Thank you, Sudhir, for that wonderful welcome. And we truly have a very, very interesting audience with us today. So we have eminent doctors, we have healthcare practitioners, we have individuals representing hospitals, we have dentists, physiotherapists, leaders from NGOs, we have business-minded individuals, policymakers. individuals from the World Bank and different foundations across the world. Not to mention our own students and students from across the world, as well as faculty. So this is truly interdisciplinary, and it represents the essence of what we are building at Ahmedabad University. We welcome you all. So we'd like to spend a large amount of time asking questions and getting your feedback on, opening it up for questions to you later on. So I'll get started right away. Let's begin with understanding what motivated you to start Project ECHO, Dr. Arora? How does it work? And what has been the impact so far?
First of all, thank you, Professor Vyas, Professor Pandey and colleagues for inviting me and my colleague, Dr. Sunil Anand. We're really honored to be here, and certainly one of the primary goals of ECHO is to be of service to India. So thank you for this opportunity. Yeah, as you mentioned, I'm a gastroenterologist, and I've lived in the US since 1980. And in 2001, I was seeing a patient at the University of New Mexico. And when I went into the clinic room, there was a 43-year-old woman sitting there. And along with her was this 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? And she said, I have hepatitis C and I want treatment for that. So I said, how long have you had it? And she said, I've had it for 8 years. So my next question was, how come you didn't come earlier if you've known about it for 8 years? And she said, I'd called your nurse and she told me that there was an 8-month wait to see you. And I live 200 miles away from you in a rural area in New Mexico. And I would have to make 12 trips, 200 miles each way to come to see you. So I understood that. And she said, I don't make a lot of money. My car is old. I had a 1-year-old child at that time. So I asked her, why did you come today? And she said, now I'm having pain in the right upper side of my abdomen. And I got concerned. I did an ultrasound of her abdomen and found that she had a cancer of her liver, which was slightly smaller than the size of a tennis ball. And it was now too late to treat her. So she passed away 6 months later, leaving these 2 children. And I asked myself, why did this woman die in a country where I have all these medicines available? I had all the diagnostic tests. I knew how to treat her. And yet, everything was available, but she died anyway, leaving these 2 children. And the answer that came to me was, she died because the right knowledge didn't exist at the right place at the right time. And that is a sort of a fatal disease. If you don't have the right knowledge, it becomes impossible for you to get the right care at the right place at the right time. So over the next 15 or so minutes, I'm going to talk about our project and what we did, and specifically focus on what we are doing in India, but also what we are doing for the COVID-19 response all over the world. So that problem that I described for that patient wasn't unique to her. Every day, thousands of variations of this story are playing out all over the world. And for example, in India, 1,100 people die of tuberculosis every year, even though the medicines are free from the government. The diagnostic tests are also free. But without the right knowledge, it's impossible to get the right care. Similarly, 1,800 children die every year from diarrheal diseases all over the world. And every day, because their mothers and the healthcare professionals don't know that simple oral rehydration and generic antibiotics can prevent the death. So our mission at ECHO is to democratize implementation of best practices for healthcare to underserved people all over the world, with a goal to touch the lives of 1 billion people by the year 2025. And we want to do this by moving knowledge instead of patients and providers. So going back to that patient, she wasn't alone. In my clinic, people were coming with this problem all the time, and hundreds of people in New Mexico were dying from hepatitis C, even though I knew how to treat them, because There were no specialists in rural areas in New Mexico. And this was a specialty disease that required a chemotherapy-like regimen in 2003 and 2001 with weekly injections and pills. So this model, I like to meditate, and I was meditating one day, and I got this idea of how I could solve this problem, that I wanted to treat all 28,000 patients, but only 1,500 had been treated. How do I treat everyone else? Because I didn't have the capacity. So the ECHO model is a capacity building tool. It has 4 key ideas to it. Amplification is using technology to leverage scarce resources. I wanted to leverage the expertise of a gastroenterologist like me, also a pharmacist, a psychiatrist. And I said I would use one-to-many video conferencing like we're using today. The second key idea is to share best practices. So I went around the state of New Mexico, which is in the Southwest United States. And I set up 21 new centers for treatment of hepatitis C. 16 were in rural clinics and 5 were in the prison system. And each center was run by a primary care clinician or a nurse practitioner. And I gave them my protocol, but not a single one of them was willing to treat hepatitis C. They said, we are afraid to do this because this is chemotherapy and we are not specialists. So I asked myself, how did you become an expert in treating hepatitis C? You were not born an expert. And when I was doing my fellowship in Boston and Massachusetts, I would see a patient present to my professor, see another patient present to my professor. And after 2 years, they started calling me a gastroenterologist. So I said, aha, I'm going to use this model to create new hepatitis C specialists in New Mexico, in rural areas, so everybody can get treatment. And then we would use a web-based database to monitor outcomes. So this is, on 2003, I started my first tele-echo clinic, where all 21 of these people would join interactively, always on Wednesday from 3 to 5 p.m. And one by one, they would present patients of hepatitis C to me, my colleagues, expert colleagues, and to each other. We call this process all teach, all learn. And in a 2-hour session, we would co-manage about 8 patients in a de-identified way. We would never take their names. And I would give them a 15-minute lecture on some aspect of hepatitis C that I wanted to train them. And I did this week after week after week. And what we found was that in a year, they actually became great experts. They had become hepatitis C specialists. In 18 months of doing this, I had done 72 such clinics. The wait in my clinic fell from 8 months to 2 weeks. And everybody was having amazing results. So we started doing research on this area. And we found that ECHO was doing many things. First of all, it was increasing access to treatment. But to our surprise, it was producing joy of work for these rural clinicians. Through a process of a social network, it was building communities of practice. We did research and published it to show their self-efficacy went up, their professional satisfaction went up, their professional isolation went down. And then, of course, we had to do an outcome study, which we published in the leading medical journal in the world called New England Journal of Medicine, where we were able to show that these primary care clinicians in rural areas and prisons could get exactly the same level of cure rates that we were getting with this chemotherapy-like regimen. And essentially, minorities had much poorer results, much poorer access to treatment. So we were able to dramatically improve access for minorities. The next thing that, of course, came was if it could work for hepatitis C, it could work for a number of diseases. If we could give chemotherapy, we could give a lot more other less simpler treatments. So this is the idea, goal of ECHO. We call it force multiplier. Force multiplication is a US Department of Defense term, which I have defined in healthcare as an exponential improvement in capacity to deliver best practice care. Why do we need 10 times? Because 6 billion people in the world don't have access to the right knowledge at the right place at the right time. Millions are dying every year. Doubling the number of specialists in the world will not help. You need 10 times. This specifically applies to India. You know, when I go to Mumbai, I go outside Tata Memorial and I see all these patients with these little tents on the side of the road. They moved from the villages to get care in Tata Memorial because there are no specialists where they live. And this problem, when I go to Africa, I find exactly the same thing. So we said we would use the echo model for force multiplication 10 times by making a nurse practitioner as good as a super specialist, which we showed in our publications. So then we started echo for a large number of areas: autism, mental behavioral health, osteoporosis, cancer, chronic lung disease, diabetes, addiction, psychiatry, opioid use disorder, pediatrics, and so on and so forth, TB, HIV in India. But we realized that we couldn't do it ourselves. There were only 2.5 million people living in New Mexico. How do we get to 1 billion? So we said we will train every university in the world who wanted to replicate Project Echo. We would give them our platform for free, our technology platform. We would give them our training of how to do Echo. It's a 3-day training. And we would support them all free of charge. Why did we need to do this? Why do people need Echo? Because medical knowledge is increasing exponentially. We have evidence that medical knowledge is doubling every 3.5 years. But a rural clinician living in a rural village of Gujarat doesn't have the ability to keep up with it. He or she is very busy. And so you need an exponential way to spread this knowledge and to mentor them. So we started training other universities, and now we have trained 246 academic hubs in the United States. Every major university in the United States is a hub. University of Washington, Oregon, Idaho, University of California in San Francisco, University of Chicago. University of Chicago is also what we call a super hub that trains other hubs. Harvard, Johns Hopkins, MD Anderson, Texas, Yale University, and all the others that are here. Currently, we have 246 hubs in the United States doing echo projects for 70 different disease areas. But again, the problem was that there were only 300 million people living in the United States. So we had to go outside the country. The country we first went to was India, a country where I wanted to give back, having got all my free education there. And I partnered with Dr. Sunil Anand and Dr. Kumud Rai to set up Echo India. And you can see now we have hubs in New Zealand, Australia, Japan, Kyrgyzstan, Kazakhstan, Vietnam, Myanmar, Pakistan, Tajikistan, Georgia, many, many countries in Africa, Latin America, etc. Since we are academicians, we had to publish and prove that it works. We have 265 peer-reviewed publications on Echo, showing that doctors love to participate. They are satisfied. Declarative and procedural knowledge increases. Competence goes up. We know this from electronic medical records. Patient health outcomes improve, and so do community health outcomes. These are the number of studies in each area. This is an example of a study from the Veterans Administration hospitals, 152 of them in the United States, showing that if their doctor participates in echo, the likelihood of death from liver disease is only half for cirrhosis than if the doctors don't participate. We went to Africa to treat, in this one country of Namibia, 200,000 patients with HIV who were not getting treatment, and connected echo with every rural hospital to start HIV treatment. This is Windhoek, the capital city, where the experts are mentoring them. And this is work, research done by the US government showing that the results were amazing. So we set up echo projects in many, many countries in Africa, 28 one-country programs. And you can see Kenya has 5, Tanzania has 5 hubs, etc. But of course, as I mentioned, my mission in life is to improve healthcare in India. So we started echoes in India for all these areas of cancer and COVID-19, but we also expanded into the area of education to mentor school teachers to be better teachers. HIV, leprosy, mental health, cancer, palliative care, tuberculosis, and so on and so forth. And you can see we have a lot going on in Gujarat, where all of you are living. We partner with the state TB, the National Health Mission, etc. So these are our partners in India who run echo projects, but most of them are the leading government institutions like All India Institute of Medical Sciences in Delhi, or PGI Chandigarh, or so 20% SGPG in Lucknow, National Institute of Mental Health and Neurosciences, Tata Memorial Cancer Center. But the others are actually government agencies like National Health Missions in Rajasthan, Tamil Nadu, Punjab, Maharashtra, and Punjab government. The central government, or what the federal government of India is our partner in ECHO for these 5 disease areas: National TB Elimination Program, National Viral Hepatitis Elimination, National Cancer Screening Program, National Mental Health Program, and the Ayushman Bharat, which you probably know about. In Punjab, there was a study where PGI Chandigarh was treating 1,500 patients a year. They published this in the leading liver journal, showing that using ECHO, in this study, they showed 48,000 patients got a cure rate of 91% using generic hepatitis C medicines costing less than $100 per year, per treatment, per cure, and now have treated 88,000 patients. So in India, of course, as you know, for all of us, every one of us, the world changed in March. So what we did is we had this huge network all over the world. We were operating in 158 countries. We had hubs in 41 countries. We did a complete shift, a 90-degree shift to COVID-19. In India, for COVID-19 alone, they have done 982 ECHO sessions, 1,450 hours of training, 296,404 workers trained, of which 200,000 are frontline workers. So we've had an exponential growth in ECHO around the world since 2011, when we published in the New England Journal of Medicine. In 2019, 236,000 people in the world participated. In 2020, 622 have participated. Our Zoom license, that is the ECHO Zoom license, in the last 12 months has had 66 million minutes of training. That is 1.1 million hours of training have been done. Worldwide, we've now trained 600,000 frontline workers, done 3,000 COVID-19 sessions. And I'm going to wrap up by saying what makes ECHO work. Team-based care. Task shifting is the idea of every human being working at the highest level of his human potential. And that requires 3 things which ECHO provides: interprofessional consultation, guided practice, or mentor-mentee relationships. And you need all 3. If you provide all 3, human performance will improve. ECHO is also a social network. It produces joy of work. We have 80 publications showing that. Technology reduces the cost of collaboration. Force multiplication is 10 times. We want to change the world. Well, what change do we want to bring in this world is the following. Knowledge is monopolized in this world for fame, money, and power. But we cannot have a peaceful world with this much inequity. This inequity all over the world, where some people are starving and others are living in houses, which have air conditioning and 3 cars sitting outside. This is not sustainable for a peaceful world. The world will have wars and famines and diseases spreading. We need to democratize knowledge and to help everyone on this earth. And the reason why this is possible, why can we do this? Why can we use ECHO to change the world? Because knowledge has a completely different physics than what I would say material resources. So let's say you are a generous man like Mr. Ambani, and you give half your wealth for philanthropy. You're going to have only half left for yourself. So actually giving money is a zero-sum game. But when you spread knowledge in a model in which all teach, all learn, knowledge actually grows. Echo has created a massive amount of new knowledge because in every echo clinic, the experts bring their expert knowledge, and these rural clinicians bring their social, cultural, economic context in which patients live. And we adapt this knowledge to the needs of a community, and new knowledge is created. Echo is a movement to change the world, and I invite all of you, every single one of you, to join us in this movement, whether you're in the field of business or teaching people economics or teaching. We have echoes for water security. We have echoes for teaching school teachers how to teach math and science. And we have echoes on how to mentor school teachers to teach students virtually in the COVID-19 world. So I invite you to join this movement. We have 120 full-time people working on echo in the United States. We have another 75 in India, led by Dr. Sunil Anand and his team and Dr. Kumud Rai. And if any of you want to partner with us, the partnership is at no cost, the technology is at no cost, and the mentoring is at no cost. Reach out to us on this email address. And after I take this slide down, which I'm going to do this instant, please write to one of us and we will help you democratize your knowledge, because service to others is the only way, and sharing knowledge is the easiest and best thing to do. Thank you all for your attention, and I look forward to the discussion.
Thank you, Dr. Arora, for that very exciting description of Project Echo and the very noble cause that you have embarked upon. We really do hope that we can all be a part of it. This is a question for Dr. Anand. Since Dr. Anand is working on the ground in India and has to deal with the daily issues of being in a developing country, how do you deal with the challenge that a majority of quote unquote doctors have no medical degree, and even the ones that do may not be really well trained? Let me elaborate a little more. Like, for instance, what minimum qualification and experience do you need of a doctor to administer specialty care versus more routine types of cases? You might need some less expertise. We would love your opinion on that, Dr. Anand.
Thank you for inviting me, Pallavi. And what you're saying is the reality. Let's accept it. If you look at the WHO's recommendation, the WHO recommends 1 doctor per 1,000 population, but in India, the figure is more than 1,700, and most of them live in cities. So villages and in the rural areas don't have doctors. That's a fact. Now, when a situation like that occurs in a poor country, non-MBBS doctors will thrive. And let's point it out. Patients are voting with their feet. They're going there, right? Now, the question is, should we ignore them and leave them in the field? Or should we do something about it and bring their level up to at least save patients? Right? I can go give many examples, but I'll give one a little later. Now, remember, I was reading about the eradication of polio. The West Bengal polio eradication program was successful by a major contribution by a person who was a non-MBBS doctor. He's the one that found loads of these patients with polio and suspected paralysis and suspected polio. So let's not discredit them. Let's also admit the fact that because doctors are not moving in rural areas, patients do need care. And in 2014 onwards, the Ministry of Health has actually recommended the Ayush doctors to go and man these primary healthcare centers, of course, with training. One small example is, look at the Liver Foundation, right, of the West Bengal. They picked up these rural, what they called as quacks in inverted commas, and went to them and said, I'll bring your knowledge up, but you need to do 3 things for me. A, stop using the word doctor, because that's a misnomer and you're misleading people. 2, stop prescribing Schedule H and X drugs, sleeping pills and amphetamines, etc. And 3, please treat certain amount of diseases, the rest please pass on and don't wait for too long. With that is what they've trained. Now, so what does ECHO do? ECHO helps in the capacity building of the healthcare system, whether it be doctors, nurses, lab technicians, and all the participants are encouraged to work within the license guidelines and build capacity within those current guidelines, right? If you ask me what's the minimum qualification, I would say if it's an MBBS doctor, I think he can provide good basic care, but they can, and in my opinion, I insist, it should be upskilled to handle more complicated cases. Remember, you heard what Sanjeev said. Project ECHO was started with the belief that general practitioners can be trained by the ECHO model to treat complicated diseases. The hepatitis C example, what he gave, is one of them. But let me illustrate it with an example, right? Primary health got doctors, if they're supposed to just use crocin, etc. But we've got 1 million new cancer patients being detected every year. So the answer is prevention. The Indian Council of Medical Science Research Institute, ICMR Institute, National Institute of Cancer Prevention, wanted to see whether we can use the frontline workers, the nurses and doctors at primary health centers to screen for oral, breast and cervical cancer. Now, what were they doing earlier? They used to do face-to-face training, go away after 5 days, and 3 months later, they found the knowledge had gone and the program wasn't really very successful. Now, what they did was they did the face-to-face training and then implemented the hand-holding process with Project ECHO over 12 months, right? Now, once that was done, they went back and looked at the study, and the study showed that not only would those people knowledge remain at peak, but increased by 5% 6 months after the course had ended, which meant that we believe it was because we held their hand through the whole process and they learned it by doing. More than 11,000 population was screened in that village. The article was published in an international journal, and therefore the process has now been accepted, adopted, and funded by the Indian Health Ministry to build capacity among doctors and nurses across the country. So yes, an MBBS doctor can take up complicated cases, but he needs to be mentored, and it is the need of the hour today.
I think
Thank
one
you
thing,
so much for that.
Professor
Yes,
Vyas,
yes.
one thing I wanted to mention is the ECHO model is a generic model. It can be used for primary care doctors, but we have lots of projects where we train ASHA workers and upskill them on one extreme. We also have projects of upskilling prisoners in the world to become teachers in the prison. But on the other extreme, we have projects not just for primary care doctors, we have projects for oncologists to be mentored by super oncologists. We have one like that from Tata Memorial Cancer Center, where the learners are oncologists. We have many projects in Africa to mentor oncologists to become super oncologists. So the model is generic mentoring model.
Right. So it seems like there's a certain level that you need so that can be trained, can be upskilled. I mean, the jump cannot be very big, but at a certain level, you can upskill every type of worker. I understand. Wonderful. So now, besides the poor quality of doctors in India, we also have problems with internet connections as well as electricity. We are trying to administer healthcare across the world using video technology, and a necessary condition is to have electricity and internet. So how do you deal with that? And can we actually work with the government to actually improve this infrastructure in the rural areas and the satellite towns? What has been your experience so far, Dr. Anand?
See, internet is an issue still, right? And ECHO, one of the things ECHO requires is a good broadband and a 4G connection for rolling out Project ECHO. I will add that over time, this has only got better. I remember what we were in 2016. We continue to face the situation, especially in the hilly areas, let's say Northeast, for example, and at the village level at the sub-centers. But at the primary health center, it's pretty good. And so what we overcome it, we just tell the ASHA workers, ANMs, instead of staying at the sub-center, just come to the primary healthcare center. It's just a couple of miles. And when they come, they can participate in an ECHO session. I remember when we were in 2015, when we started, our broadband used to be so poor that we would tell the participants, please switch off your videos to conserve your bandwidth. And today it is such that we tell the participants, your bandwidth is good, please could you put your video on? So things have improved quite dramatically over the time. And like Sanjeev mentioned, in the last 12 months, 1.4 million people from India logged in on the ECHO Zoom account. So it does happen. In the United States, the figure is 500,000. Let me just see if I can pull up a photograph to show that it does work, right? It is an issue. I'm not denying that. But let's see what it is. Where's the photograph? Yeah. This was a program that we ran for the Ministry of Health for Ayush doctors across the country. Look at the spread. Every state and union territory was able to participate. 555 districts with five.
We can't see, Sunil, the map you're trying to show us or something.
Really?
Just move your slide a little bit so we can see the correct thing. Right now, we're only seeing text.
We're only seeing text. Okay. Oops. Right. Now can you see it?
No, we only see text in red.
Let it be.
Stop share and try again. Yeah.
I don't know where the screen is gone now. Anyway, ouch. It'll have to happen now, right? That much for Zoom. Okay, sorry about that.
That's okay.
Okay.
That's okay.
So therefore, internet is only getting better. That's what I would say, right? The same thing with electricity. There are issues. I'm not denying that, right? But over a couple of years, this will get sorted out. But the cell phone and the 4G is pretty good across the country. In fact, a lot of our participants are logging in through their smartphones and to get onto the echo session. In fact, one of our programs in NIMANS runs completely on 4G network. Like I mentioned before, in Maharashtra, remember, over 150,000 frontline workers in Maharashtra joined the echo session through the tablets. Sanjeev always told me, do not let the perfect be the enemy of the good. Let's go with what we've got rather than what we don't have. And I think over time, things will get better.
That's very optimistic. Thank you. Thank you for that piece of optimism. So we've talked about some of the supply constraints in delivering this healthcare. But in terms of demand, Dr. Arora, is there a certain willingness to pay for this type of healthcare that you deliver? Let me elaborate. So we know that most rural citizens go to private doctors rather than to public healthcare facilities. They prefer to go to private doctors. So there is a certain amount of willingness to pay, but is that enough to make the echo model self-sustainable, or are you relying on external sources of funding such as from grants or other types of resources? Dr. Arora?
Yeah, thank you, Professor Vyas. That's a really important question. I think that the first important point I wanted to make, of course, is that you mentioned this thing about poor doctors in India. My own experience in India has been somewhat different, which I wanted to share. The doctors in India are pretty amazing. I think we have a system design problem of healthcare in India rather than poor doctors, because there is an insufficient doctors. They're geographically mislocated in cities versus villages, but the quality of the doctors in general is good. So I hope that with system redesign, we can make a huge difference. The second, I think, point I wanted to make about this, the money part, was that in India, being an Indian myself, as you pointed out so correctly, even poor families are willing to pay somewhat for good care. But at a larger level, at a global level and at pan-India level, there is really no private system, Professor Vyas, that can provide good healthcare to every citizen of India. That doesn't exist. It doesn't exist in any country in the world. And the reason is healthcare generally tends to be somewhat expensive because the HR inputs are expensive, and often the medicines can be expensive, the diagnostic tests are expensive. So in every country in the world that has done a good job for poor people in healthcare, which many have, the government takes the responsibility. There is no private solution for global healthcare for poor other than government involvement. So what is the strategy that ECHO uses? ECHO uses the strategy to partner with governments to enable them to use their existing dollars more effectively, to force multiply the limited expertise they have in a university in Delhi or in Mumbai or in Ahmedabad, and multiply it and mentor their healthcare workforce, whatever that may be. ASHA workers, A&M, doctors, Ayushs, to work at the highest level of their human potential. And that will create a much better health system. And of course, to the extent that patients have to pay, they will pay. But to expect a poor patient to cover the full cost of their healthcare, I have never seen that animal in the world, okay? So if it does exist, it will have to be hiding somewhere because it doesn't, I have never been able to find it, okay?
Sure, not the entire amount for sure. Some
Yes.
kind of
Yes.
public-private partnership is inevitable. I agree.
Yeah.
Exactly. But then how do we attract the best doctors into your ecosystem? I mean, they have high opportunity costs.
Yeah.
A lot of them working in urban centers have their own patients, and they are very tight on time. It's impossible to get an appointment. How do we attract them, and how do we make them stay within the echo model?
So, Professor Vyas, I think that you are absolutely correct that there is a tremendous opportunity cost for a specialist to democratize their knowledge and not spend their time making more money or whatever else they want to do with their time. I think that there is two really key principles. And I'll start by a quote from a Jewish doctor in Africa called Albert Schweitzer, which says that I don't know what your destiny will be, but one thing I do know for certain, that the only ones amongst you who will be really happy are those who have found a way to serve. So really, at some point in the life, every expert does come to this realization. And I myself am a student of yoga. I have studied the Indian teachings and I have teachers in that area. And I can tell you that there is universal belief that in order for humankind to be happy, they have to spend their life in service. That's probably why you're working, Professor Vyas, in the University of Ahmedabad, rather than working at the World Bank full time. So the question then is, why do they do it? I have never had a shortage of experts in the world. My problem, Dr. Professor Vyas, was that I was a world expert in hepatitis C, but the only people I could help was the people I could see myself. That was insufficient. I was going to retire and take all this expertise into the grave with me. I wanted to help 100 times more people, 1,000 times more people. That motivator was much stronger than making a little more money. Now, if I was starving, definitely I wouldn't do this, but I was doing well. So all over the world, in every country, I'm not talking just about India, in Africa, in Sudan, I'm finding people who are willing to democratize their knowledge because it has tremendous personal gain for every human being to serve his fellow human beings. And that is the driver of ECHO. That's the reason it works. That's why it's spreading exponentially around the world. And that's why I'm inviting every one of your listeners to join this effort. They have something they can share, and we will help them share it.
Wonderful. That's wonderful. So moving now to the current situation of COVID, Dr. Anand, in India, we have this huge out-migration from the urban centers into the rural areas. We have more than 6 million individuals that have migrated. And so we have this rising COVID situation in Uttar Pradesh, Rajasthan, Bihar, where the migrants have come from. So what has Project ECHO's experience been handling COVID? And can you give us some details on what you're doing to curb the situation from increasing? Dr. Anand, you're muted.
COVID has brought out a different animal altogether. It's a different situation, and ECHO had to reposition itself, right? We went from the teaching model into a dissemination model. Now, to control the COVID thing in India, right? We do have a serious problem in the sense. Has disrupted a lot of the healthcare system and exposes flaws. If you look at it, the UP government or chief minister's remark was that 75% of people that moved from Mumbai and 50% that moved from Delhi were actually positive. And therefore, they are the ones that are gone and turned it from a urban to a real disease, right? And now this will bring its own challenges over the period of time. Now, what ECHO did was, out of all the, I think we had 34 partners, out of them, 32 of them repurposed their clinics, stopped their clinics, and went into doing just COVID dissemination. That's what ECHO really did. And use the power of the individual networks to reach out to all these states, NHMs, and ran their programs to get it. And that's why over 1,000 sessions with over 150,000 frontline workers were trained. So states like Maharashtra, Tamil Nadu, UP, and Punjab started it, and now Gujarat, Rajasthan, Maharashtra, Uttarakhand have all joined in, and the NHMs have taken this one. So we've partnered with them and taken it forward. That's how ECHO has actually repurposed itself in the COVID times to get knowledge to the people. It's not the traditional model that Sanjeev described where you teach people. It is more of dissemination and getting the information out. Even the Assam government has used us to get information to migrants as to how to get home, or into financial inclusion as to how to get money into their pockets. So that's how ECHO actually had to reposition itself, or repurpose itself for the COVID. It's not the typical model that Sanjeev talked about.
I see. But now what if it starts, and I mean, it has already started spreading in states like Bihar. So what can we do to, in fact, can there be some type of specialty care that can be given to these individuals that are, I mean, we do not have healthcare facilities to support the population that's getting sick. So, I mean, what can Project ECHO do in terms of its model to actually help these patients get treated? Can we somehow connect them to centers in Germany, Italy, Spain, where they've been successful in curbing the crisis?
The answer is yes. But currently in India, the rule is very simple, that all dissemination of knowledge on COVID has got to come from the government of India. So it'll have to be a local solution to it, right?
I see.
Partners, for example, Sanjeev and all have got a huge library, but unless asked, we cannot use that. It's only government policy, and NHMs are actually doing it. So that's what it is. But other than that, for teaching them how to, test, isolate, quarantine, and as well as, sort of contact tracing, that is part of the management of COVID. Remember, according to the government figures, 95% of the people who are affected are actually asymptomatic. It's only 4%, 4.98 to be exact, actually that are into hospitals for treatment. So there are certain attempts being made, like All India did for ventilator training or respiratory training, where doctors logged in and they were taught what to do when a patient enters an ICU. Currently, now that it's spreading, a lot of governments have taken over small nursing homes in Delhi. They've taken over nursing homes and admitting patients there. Yes, this model now can be used for getting All India Institute to connect with these nursing homes and then upskill them to make sure that the patients in the ICU are better treated. And then, the same model, ECHO model of mentoring them through the process. So that's how this will really go out. So two parts, one is dissemination and the other is treatment.
Professor Vyas,
yes,
the COVID-19 problem is very, very serious all over the world. And in low-income countries, they have this enormous difficult choice to make: livelihood versus health. And locking people down in the United States and for example, in Germany and other countries where they controlled it, they have very elaborate social security systems that large checks went to people. Their salaries continued in Germany while they were staying at home. India, that solution doesn't work because of the absence of people have to work. And so for that reason, the focus of ECHO is in different areas. It's in prevention, amplifying the public health response, teaching about testing, teaching about prevention, teaching about contact tracing, teaching about isolation strategies, teaching about data. Also amplifying the care delivery response, which is how much oxygen to give, what ventilator to use. Should you use anticoagulation? How should you set up a COVID-19 floor? There's all kinds of things in care delivery, but the most important use of ECHO is yet to come. And that is the world is going to face an unprecedented challenge in about 8 or 9 months. And that is something it has never done in its life before, the world. And that is vaccinate 7 billion people in a very short period of time. The vaccine will become available. The challenge is, how do you get it to 7 billion people? So ECHO is going to be used everywhere in the world to train people on vaccine delivery, because you will need a much enhanced workforce and people will need to be educated. Why should I take the vaccine? What are the side effects? How will you manage them? And so much to be done. So I think that there's the whole spectrum of problems, and of course, care delivery is one of them.
Right. And so, can you tell us a little bit about your experience with other governments, from governments in other countries to fight diseases other than COVID? Maybe you can talk about COVID as well as other diseases. Like, does your experience vary by country?
Definitely, because what happens is that you cannot bring US best practices to Sudan. When we first brought ECHO to HIV to India, they said, yeah, we love ECHO, but your guidelines are crazy. They cost $100 per day for treating HIV. And our protocols are a $1 a day protocol at that time. Now it's 50 cents or something like that. The rupee has depreciated since then. But the fact remains that the key point, the principle that Sunil mentioned was, you don't want perfect to be the enemy of the good. Yeah, the $1 a day treatment is not as good as the $100 treatment, but it gets you 95% of the way there, and that's pretty good. So what we do is we have to adapt in every country. We cannot come to India and say every person needs an N95 mask. That will create riots on the street. So we have to amplify in every country, including South Sudan, which is, a war-torn country. There are some experts in the government who have the knowledge to do the right thing. The government knows what to do. They just don't know how to do it. So we are about amplifying local design, local goals, local expertise, because they have best practice is expert knowledge is only a part of it, Professor Vyas. There are the local circumstances, the barriers to care. Who do you have? Our entire HIV program in Africa, which is our largest program, runs on nurses, basically. That's what they have. And Dr. Anand has just started a massive ECHO initiative in training ECHO nurses. Why did we do that? Because we came to the realization we have a lot of nurses here. We may not have enough doctors, but we have a lot of nurses. Why don't we upscale them? So it's all local solutions. Professor
Absolutely, absolutely, absolutely. So we have lots of different types of practitioners in our audience. And we have doctors, and we have educators, and we have physiotherapists and hospital administrators, and they're all writing questions and wanting to know about how to collaborate. And so what we're going to do is we're just going to go ahead and start taking a bunch of questions and seeing what your responses are for the different sectors, because I think everyone is really eager on knowing how to participate and collaborate. But
first, I'll start with asking my colleague Sunil to put his email in chat. Otherwise, all the emails are going to come to me, Dr. Sunil Anand. So you need to share the emails here. Put your email in the chat. Okay, go ahead. Sorry, interrupt you, please.
Okay, so do you want to start the questions?
Yeah, I have got a lot of questions, and they are very pertinent questions. The first question I would like to put it is by Satwa Basavada, Mr. Satwa Basavada, and is asking that would imparting training to informal healthcare workers, self-declared healthcare workers or doctors not registered, help improve health outcomes in rural India? Because these are informal healthcare workers, they are not trained. So
I'm convinced.
I think we addressed that, Sudhir.
Okay.
Go ahead.
I'm convinced it will do that. I'm convinced it will do that because of the fact that's where the patients are getting care. And again, Don't make the perfect of the enemy of the good. And let's not in India get into these artificial barriers that, oh, I'm not an MD doctor and so I cannot do this. And of course, we as doctors are at fault. We create these artificial walls to protect our own professions. A nurse can't do this and a this can do that. And I think these are very toxic for humanity. We should allow and enable the person on the ground, who he is, what he's doing, and enable them to work at the highest level of their human potential and help them fulfill their dreams, and start with an attitude that everyone in the world wants to do good. The Ayush doctor does not want to do bad for his patients. If you help him, he's going to do better.
Yeah.
And that's the idea that Echo we take.
Yeah, next question is, I think that will go to Dr. Sunil Anand, and it is by Colonel Sunil Nathan. He's asking, how far has Project Echo India been able to influence the government of India on this crucial aspect?
Uh, a lot. I would say the government has a very large buy-in to ECHO. First of all, we have an overarching agreement with the Ministry of Health, right? That all national institutes and medical college, national medical colleges, institutes, hospitals come under the ECHO platform. All national programs, whether it be TB elimination, cancer screening, hepatitis C control program, are all under the ECHO program, ECHO platform. Also, now, like Sanjeev mentioned, the upskilling and training of 2.5 million nurses is also being put on the ECHO platform. So the government is a very strong partner. In fact, most of the 34 partners we have are government institutions. So there's a very large buy-in from government into our programs. And state national health missions as well. Because remember, delivery of healthcare is a state subject. So all these states we mentioned before are actually signed partners, and that's why their NHM, national health missions, are taking it up.
Yeah, since this question has come up and we are talking about the delivery of healthcare and role of state, there are a lot of questions that came that when initially Dr. Sanjeev Arora questioned about and also pointed it out to improve the system design approach in India for healthcare. People would love to know, I mean, what do you mean by that and how can it be tackled effectively?
Yeah, Sanjeev, go ahead.
Yeah, so fundamentally, system design is a core idea that you should design a system to meet the goals of a system, right? So what is happening is the core values in India, the core religious values. So what are the three religions in India? There is Hinduism, Muslims, Christianity. All of these have core values that there are some things everybody should have a right to. Good healthcare is one of them. We want to do that. But the system design is such, which is our fee-for-service system. We spend so little on healthcare in India. We spend just a couple, 2-3% maybe, whereas the US of a much larger GDP spends like 17%. So you can imagine per capita, we are spending like 100 times more on healthcare, right? And so in India, the only solution that can work is a public health system, which is robust. So that right now the health system in India is designed that only the rich people can get good healthcare. That is just a fact of life. And that is misaligned with our values. It's misaligned with our goals. So that's the first step of redesign. Alignment of design with goal and values. The second part of misdesign is in a country where the primary problem you have is shortage of expertise available, because we have tons of generic medicines. That's not our problem. We can make them for 1 cent. We are the supplier of generic medicines to the whole world, basically. Period. Okay. When I take an ibuprofen tablet in the US after playing golf, right, it's made in India. So the problem is, it's not a medicine shortage, it's a knowledge shortage. And we have designed the system that every specialist at the University of Ahmedabad, I don't know if you have a medical school, but every specialist, all he does is see patients and train medical students. If you have a government specialist, their primary role should be to democratize their knowledge and mentor other people. And I'm going to take a stab at the University of Ahmedabad right now. Your experts, okay, your primary role also should be to mentor other teachers in the smaller colleges in India. It's bad system design for a country like India that all you have your expertise in the University of Ahmedabad and all you train is your own students. The fact is, what if you were, I was having this 1-hour conversation just 2 weeks ago with an economist by the name, and political science expert by the name of Kanti Prasad Bajpai. He works at he was my classmate at St. Xavier's in my 10th grade, and now is a world economist in Singapore. So I was telling him, why don't you teach all these other colleges how to do better political science and strengthen our democracy instead of doing consultation after consultation? So I think that democratization of expertise for common good is a different system design than me seeing patients myself. I go to All India Institute Medical Sciences, and in Delhi, every specialist has got waiting rooms are filled with 80, 90 patients waiting, and he's seeing one patient after another. That's bad system design.
Okay.
That's what I was having, an 8-month wait to see me. And so I said, I'm going to create 21 of me, basically. And that's the system design problem that we have. It is soluble, but we have to rethink this design for India. In every area, mentoring school teachers. You know, I went to a school called St. Xavier's School. I had amazing teachers. You go to a village and they don't have great teachers there. We need to mentor every school teacher to be a better teacher. So that's the overall system design issue.
Yeah, thank you so much. There are a lot of questions regarding one thing, which I'm just putting it like this. Particularly, that also came from Chakradhar, that you please discuss more on how non-doctors can contribute in this Project ECHO.
Okay. There are multiple ways to contribute, depending on what your skill set is. If you're a professor, right, you must ask the question. Let's say, Professor Pandey, I don't know what your expertise is. You must ask the question, can you start an ECHO project? It will cost you nothing because we'll give you our technology, we'll give you our training to mentor other teachers of your field, whatever that may be in India, to have 10 times more impact than otherwise you would have. Okay. If you're a corporation, you could use ECHO as part of your CSR activity to have greater impact. So if you are doing training of community health workers and you're training 500 a month, the question is, can you use ECHO to train 5,000 a month? If you are a doctor, of course, you know what to do. If you are a math teacher who's a master teacher, you could start an ECHO and take 30, 40 math teachers in villages and do an ECHO with them to mentor them. If you are a leadership expert, and we have ECHOs on every one of these. If you're a leadership expert, let's say you are working for Tatas and you are an expert in leadership, you could start an ECHO for school leadership, principal leadership training. We have many of those in the US to train school principals to be better leaders. That's also ECHO. We use case-based learning and all teach, all learn to make it work. If you are an affluent person, you can contribute to ECHO India. You can write a check because they are what they call an NGO, and you can get a tax deduction. So if you're rich, you contribute in a different way. If you have knowledge, you contribute, but everyone can contribute. If you are a learner, you can join an ECHO and learn. And that will also contribute to society because you will increase your expertise and help lots of people.
Yeah, thank you so much. There is one question by Professor Sonal Yadav, and in India, she's asking in this context that ASHA workers are not getting enough monetary benefits for their effort. Is this reason for poor or weak healthcare system in rural areas?
So Neil, why don't you take that?
Yeah. I've heard this before as well, that the ASHA workers not being paid well enough, but let's not blame the failure of the system. I don't think that's the real reason for it. ASHA workers work hard, and a lot of the work that they are doing is there. But I don't think I would say that because they're not being paid is what they're not doing a good job. Sanjeev, your thoughts on that?
Yeah, I think, it always, it's absolutely the wrong idea to think that money is the only motivator for human action. Okay. That is not true. That has not been my experience. We have different reasons for human action. And at different stages in our life, those reasons change depending on our circumstances. You're right that money is important for a poor ASHA worker, but she doesn't go to work saying that I didn't get a good salary, so I will do only 50% effort. That is not how humanity works. That's the same as people telling me in America, which is all complete nonsense, that innovation will stop here because if we didn't allow people to charge $50,000 for a medicine, which we do, because Edison invented electricity and Newton developed the laws of motion before all this private capital business came into play. There are other reasons for human innovation, for working hard, and I can tell you that yes, more money is good for an ASHA worker, but it is not the driver of their action. If you give them better knowledge, what do they do? What does an ASHA worker do? She goes from home to home to home, helping people. Do you think at that time she's thinking, I didn't get paid, so let me give wrong information to this? No, you equip her with the knowledge and she'll do a good job, basically.
Yeah. There is a very crucial question by Sandeep Sachdeva, and he's asking, can this generic model be customized for non-healthcare knowledge dissemination? For example, improving knowledge about industrial safety among workers, and if yes, how?
So the first step of how is, you should write an email to either me or Dr. Sunil Anand. Then you should understand ECHO a little bit more. Once a month for the entire world, I do a 90-minute session, which Professor Vyas has attended, where we describe ECHO in more detail. If after that you like it, then you will attend a 2.5-day, what we call immersion training on ECHO. After that training is done, we will give you your own technology licenses, which are our worldwide Zoom platform. All of this is free. Access to our Project ECHO resource library, which has intellectual property from all the major universities in the world. We'll give you a CRM type of solution, which is called ECHO Spark, to track your ECHO projects. All this is free. And then we'll give you a relationship manager who will help you launch your ECHO. But the short answer is absolutely, for industrial safety, it would be an amazing use of ECHO. No question about it. We'll show you how to do it, but I don't want to use more time than this on that question.
Sudhir, I'd like to ask one question that got maybe left behind just up front. So how is it possible to train these healthcare workers in physical examination or any treatment that needs hands-on work? This is from Maushami Kuvawala. She's a physiotherapist. So I'd like to ask that.
So I think the only comment I have for you, Maushami, you asked a really beautiful question. And what it basically says that you cannot do everything with ECHO. What we can do is we can train people to do a good physical examination. So you have to remember that no patient ever comes on ECHO. And if I didn't make that clear, that is the case. What we do is only doctors and nurses come on ECHO, community health workers. We enable them. We do a training program on technology for them to do a physical exam. If the perspective you have, Maushami, is that it won't be as good as the one I would do myself, because I'm a gastroenterologist for the last 30 years, and I've done like thousands, it won't be as good. But remember, these people are getting nothing. And we're going to train them on how to do a physical exam. And then in the ECHO, they'll share their knowledge. And we as experts will catch things. We'll give them feedback. And over time, we'll make them better. But it will not be as good. But remember, Mashami, what is happening is, for example, in physical therapy, you have many years of training that have made you a physical therapist. You cannot make a community health worker that. Okay? But if you did an echo for community health workers and taught them the ABCs of physical therapy, of how to help, we have joint families, right? And I'm having this problem in my house, so I'll give the example. I have a mother who's 87 who lives with me. Her balance is poor. If you started an echo and physical therapy, I would join that. And you could just teach me some simple exercises of how to improve my mother's balance. Are you following the story? If you teach physical therapists the ABCs of physical therapy, just imagine each ASHA worker has 1,000 homes they take care of. You train 100 of them, and now you will have helped 100,000 patients get better physical therapy, which will never be as good as Mashami's. But guess what? It will change the world, Mashami.
Thank you. Thank you. That's a wonderful answer. Sudhir, you want to go ahead with the questions?
There are other questions as well, and which are related to echo. So one is that the community volunteer is one of the strongest pillars of community in rural and urban setting. This is by Isha. How to start building their knowledge to address health issues of their community. What are the ways through which we can train these people, even in rural part of the India?
Sunil, please take that. And I think they want you to describe your ASHA worker program in a little bit more detail. We have 1 million of them in India, each helping 1,000 people. Yeah, go ahead.
So the ECHO model is used to train community health workers. Let's just take the case of the ASHA workers. There are 1.3 million of them. And if we train them well, that's where rural healthcare will improve. Now, we are doing echoes to build their capacity in many diseases. One is we connect them to institutions. The level, let's say a district hospital or an MBBS doctor will train them. Well, I give an example, cancer screening, but also through the government of the 12 disease areas that the government wants, hypertension and NCDs. That's how they've been trained currently. The ASHA worker training program, currently we are doing in 3 states, Haryana, Gujarat, and UP, where they're picking up a large number of ASHA workers and training them through the ECHO model, connecting them to teaching institutions like medical colleges, etc. Likewise, with the other NGOs, we are also tied up with other NGOs and training their people in their skill. For example, skill development for community healthcare workers. That's how ECHO is actually reaching out to the community.
Yeah. And so let me add to that question with a specific example. Okay. Let's take a disease, type 2 diabetes in India. Okay. We know it's an epidemic. Central obesity, that is large tummies, are an epidemic in India, right? So the question is, and we know that the Indian genome, us, me and you, are much more susceptible to heart attacks and type 2 diabetes because of the genetic framework that we have. So let's just take that. So now you want to train 300 million people on how to prevent type 2 diabetes. How are you going to do that? You think you have enough endocrinologists to do that or enough primary care doctors? No. Now, let's imagine a community health worker program in India where we train them on diet and exercise. That we train them not to become doctors, on how to talk to a patient. What should they eat? How should they exercise? How should they suspect type 2 diabetes? That means they can do that. They can take the circumference of the chest, and then they can take the circumference of the belly and examine the ratio of that. And that will give you a pretty good idea what is the risk of type 2 diabetes. They can educate you on which are the vegetables and fruits that are available and in season that you can eat, which are not that expensive this month, so that you change your carb input. And we know that if you just reduce your refined carbs, you will lose weight massively. They can tell you one simple thing, which is the single most important intervention, what we call fasting. that if you have a 16-hour gap between your dinner and your breakfast, you will reduce your risk of diabetes by more than 50% right there, basically. So you have your dinner at 6 p.m. and you have your breakfast at 10 a.m. So what I'm saying to you is, let's not complicate cancer chemotherapy with what actually patients need for their health. Okay. Most of health requires 5 things. Okay. A good diet, good exercise, good thinking, your thoughts determine. So simple meditation practices can change the world. Doing good work, encouraging them to serve the other human beings. These are the breathing fresh air. These are the simple things that determine how healthy we are. And so we can teach all this through community health workers. And I encourage you to work with us on that.
Thank you so much for this. There is a very crucial question by Vinay. And Vinay is asking, does Project ECHO also include AI-based technology for self-diagnosis of known diseases? There is a lot of work going on training AI-based model. Is there a network to get such data and use it to make AI-based models more accurate?
So what we are doing is because millions of conversations are occurring on real patients every year, we actually, in partnership with Mr. Nandan Nilekani, some of you may know him.
Very well, we all know him.
Yeah. Are developing an Echo digital platform, basically. What that platform will do is all the conversations that are going on in Echo, which are millions every year, right? Each 2-hour clinic can have 8 cases presented and expert advice. It's going to trap that into text and then use artificial intelligence to analyze that knowledge. And what will the benefits to the community be ultimately? One is what we call positive deviance. Identify positive deviance. So for example, we would say, Professor Pandey is treating hepatitis or diabetes in so-and-so place. His results are much better than Professor Vyas's. What is he doing differently? Second is what we call failure analysis. A particular country is not performing well because we know that, because cases are being presented. What can we do? What can we teach them to improve their performance, system performance? Third, it will have data to show that why are so many more patients with pneumonia being presented in Wuhan echoes right now? What is going on there? So that we can track the onset of diseases. It will have a lot of other functionalities related to artificial intelligence, but I won't spend more time on that. But this is not developed yet. We have a team in India of about 15, 20 people, another team of 10, 15 people in the US, working very hard day and night to make this a reality. And we are actually fundraising for that right now and talking to philanthropists who want to partner with us on that. And that's definitely our future.
Thank you so much. This is the last question that I have. It is from Nikhil. Nikhil is saying, is telemedicine incorporated in Project ECHO? And if yes, what is the extent of its role in ECHO, telemedicine?
The biggest role on telemedicine of ECHO is used right now in the world to teach people telemedicine, how to do telemedicine, because people are seeing their patients remotely, but they don't know how. They've never been trained to do it. So we've just completed which I moderated, a 3-part global series. Thousands of people from all over the world, doctors joined to learn how to do telemedicine. And we have just launched a 10-part series in partnership with the US government and on how to train people to do telemedicine correctly. Telemedicine is, I'm a doctor, I want to see a patient remotely. That's telemedicine. That's not ECHO. and we are enabling that. If any of you are interested in joining that 10-part series, it's a global series. We have already had the first session. 1,700 people from all over the world attended it. If you want to join that, write Sunil Anand or me an email, and we can, we can send that information to Professor Vyas and Professor Pandey, and they can disseminate it in their network. But I think that that is a very important series we are just launching, sponsored by the US government. So that's our goal. We like telemedicine. It does good, but it's not a force multiplier. If I see one patient in a rural area, I see one less patient in New Mexico, the total number of patients doesn't go up. And what I tried to describe in my talk was, I need 10 times, guys. I need to mentor other people to be as good as me. And I want to thank my colleague, Dr. Sunil Anand, for joining, and appreciate your participating.
Sure. Since we have a couple of minutes, should we see if any individuals want to ask a question? You can unmute yourselves and ask a question directly to Dr. Anand or Dr. Arora. We have a couple of minutes. We have a question from Amol. Amol, do you want to ask your question live? Amol?
Hi, Dr. Arora, and it's just fabulous. I mean, I'm so inspired. I think just the right kind of conversation one could have today on a Saturday evening here. So my question is that, though you've touched on how the Indian governments have been responsive, but how has the experience been talking to the state governments in India? Because we learn that there's a lot of there's a lot of diversity as far as state governments are concerned. So could you share some of your experiences with talking to individual state governments? Because we learned from the earlier conversation with Dr. Nachiket Moore in this forum here that there are a lot of differences in the way states function. So could you touch something on that?
I think it's a really important point. I'm going to have my colleague, Dr. Sunil Anand, wrap this session up with that answer.
Like the central government agreements, we also have agreements with a lot of states in this country. I mentioned Maharashtra, Gujarat, Uttarakhand, Tamil Nadu, right? And they have run this program. In UP, for example, when we ran the program through KGMU, King George's Medical College, and their health and wellness centers, once that was shown to be a success, they've actually added 5 more, what they call as echo nodal centers in Gorakhpur, Banaras, etc., to add to that. So a lot of states are doing it. The other place where the states are really taking up big time is tuberculosis. We have almost all the state tuberculosis officers lined up and doing echo clinics. We have equipped over 73 centers. So it depends on state to state. Some states are much ahead. Bihar, for example, we do have a tough time, but UP, Maharashtra, Gujarat, Uttarakhand, Punjab, Haryana are working well with us and full agreements, and in many diseases, including the health and wellness centers and tuberculosis. Remember, we are also we have national programs which are being implemented by states. So states have bought in as much as the central government, of course, with some few challenges, I will admit, but they have partnered with us.
But Amol, you're making the point that leadership matters, and it's very disheartening to see the outcomes in Uttar Pradesh and Bihar so much inferior to Karnataka and Kerala. And it's heartbreaking. And ECHO won't solve that because leadership matters. Democracy matters. Whom we choose as our leaders and what we prioritize matters. ECHO won't change that. I was trying to ask Kanti Prasad Bajpai to teach democracy to college professors, political science, because at the end of the day, ECHO can do nothing without the right policies. So I think all of this is a holistic whole, and we are acting on a part of it. And I want to thank Professor Pandey, Professor Vyas for this opportunity to speak to all of you. It was such a pleasure.
Sunil, Sanjeev, can I ask a question?
Sure.
This month I quit my job to start something in Gujarat. So I have the buy-in from the district health officer in Anand, and I want to work in villages where basically I'm getting donations of equipment, and I want to see if I can get an electronic health record for everybody. What advice would you have me? Of course, I'm going to come onto the ECHO platform at the earliest. What other advice you would
Chakradhar, I think that it's a long answer. So I think what we would do is, can you write us an email to have a separate conversation on this? Because I think this is a complex question. We would need a much deeper understanding of your goals, or what your, etc. But thank you for your question. I'm so delighted that you are pursuing a path of service.
Thank you so much.
We have one last question from Saurabh Sarkar. Professor Sarkar, would you like to ask your question real quick?
Yeah, I have just an academic question on the results of the positive findings of the eco that you have published in several journals. Are these analyses based on observational studies, or have you done some RCTs to establish your claim? Or means just a question?
Yeah, I think it's a very good question. We've done prospective cohort studies. So that's the highest level of studies we've done. There are several cluster randomized trials ongoing right now. But we have, you may be familiar with a technique called propensity score matching. And we've used propensity score matching to, which is a technique to make prospective cohort studies mimic randomized controlled trials, and which have shown really powerful results. And then there are certain studies, sort of, that are absolutely, it's like saying that it would be like doing a parachute test. Okay. Do you understand what I mean by parachute? You know, when nobody's done a randomized controlled trial to show that parachutes work, right? Because you know, half the other people, the other half will have to jump off the plane without a parachute to prove that parachutes work, right? So in the parachute test, why am I mentioning in Punjab? You know, people were dying of hepatitis C, and we knew 1,500 patients were being treated, and we treated 88,000 patients and got 91% cure rate. It would be highly unethical to do. So in many parts of, when we try and design a randomized controlled trial, sort of, we run into major ethical issues, because where we go, people are getting no treatment. It's not a matter of they're getting X and so we'll give them Y. They're getting nothing. And so basically putting them into control arm violates there is a very fundamental principle of randomized controlled trials. It's called equipoise. So I know you understand all these principles, but since you asked the question, equipoise means at some level, you as the principal investigator must understand that both arms are roughly equal. And you cannot ethically ever do a randomized controlled trial anywhere in the world without equipoise. Then you are testing the idea if you are better. But the null hypothesis says, look, it's equal. So we have never been able to have an ethical committee say in low-income countries or anywhere, even in the United States, that there is equipoise when there are experts helping sort of manages patients versus, you know, somebody who has no clue, because knowledge is increasing at such an exponential pace. So we have done cluster randomized trials, and there is step wedge design trials going on. But it's a complex answer, but I hope I gave you a concept of what the challenges are and what's going on. Okay.
Well,
Yeah,
thank you so
I
much.
request Professor Pallavi
Yeah.
to close this. Yeah.
No, Sudhir, go ahead. I was just saying thank you so much for getting up so early in the morning, because it was like 7 in the morning in New Mexico when Dr. Arora started out. So thank you so much. Thank you very much for all the participants. This was an enlightening discussion. We're all inspired, and we're all trying to see ways in which we can be part of your movement. So thanks again. And thank you all for joining. You'll have been a wonderful audience.